السلام عليكم everybody. بسم الله الرحمن الرحيم وبه نستعين. Today's presentation will be part 1 of sympatholytics, in which we'll talk about centrally acting sympatholytics, ganglionic blockers, and adrenergic neuron blockers. We'll have a quick revision first, where we said that drugs which act on the sympathetic nervous system, they might be a sympathomimetics. Sympathomimetics, they are drugs which produce action similar to the activation of the sympathetic nervous system. We classified them according to their classes into directly acting sympathomimetic, which act as an agonist on the sympathetic nervous system, or indirectly acting sympathomimetics. Directly acting, we said that they act as an agonist on the sympathetic nervous system, on adrenergic receptors, and usually they are different in their selectivity and their potency at the adrenergic nerve terminal. They have very important clinical application, and we have described that in details in the previous presentation. Indirectly acting sympathomimetics, on the other hand, we have said that they act by the release of noradrenaline, and we talked as well about their action and clinical indication. The second group, which acts on the sympathetic nervous system, they are known as sympatholytics. And from the name, lytics means they produce lysis of the sympathetic activity, i.e. they antagonize sympathetic activity. They produce action opposite to the activation of the sympathetic nervous system. Okay? So this is the goal of this presentation. We'll talk about the classification of sympatholytics, how they are classified according to their site of action, as we will see later, and we'll talk about the action and the clinical indication of three groups, which are the centrally acting sympathomimetics, ganglionic blockers, and adrenergic neuron blockers. These three groups, as we will see, they are known to produce what's known as sympathoplegia, or sympathoplegics, because they produce paralysis of the whole sympathetic activity in the body. Okay, so these are the goals of the present presentation. So first we'll talk about the classes. What are the classification of the sympatholytics? They are classified, as you can see, into four major groups. First group, number 1, this group, they are known as centrally acting adrenergic sympatholytics. These drugs, they act as alpha-2 agonists. As we have said before, alpha-2 activity is always inhibitory. They inhibit sympathetic outflow centrally. As you will see in a few minutes. So the first group, they are known as alpha-2 agonists, which we talked about them before. These drugs, they inhibit sympathetic outflow centrally from the medulla. This is the first group. The second group, they act at the autonomic ganglia. They block the nicotinic receptor in the autonomic ganglia. Therefore, they are known as ganglionic blockers. Okay? So, first group, they are known as alpha-2 agonists, which inhibit the sympathetic outflow. The second group, they act by blocking the sympathetic and parasympathetic ganglia, the autonomic ganglia. They are known as ganglionic blockers. This is the second group. A third group, they act on the adrenergic nerve terminal. Third group, they act at the adrenergic nerve terminal. They either prevent the release of noradrenaline from the nerve terminal or prevent its storage, as we will see later. This group of drugs, they are known as adrenergic neuron blockers. Adrenergic neuron blockers. Okay? So we have centrally acting alpha-2 agonist, ganglionic blockers, or adrenergic neuron blockers. Okay? These three groups, group 1, group 2, and group 3, these three groups, they inhibit sympathetic activity to all body organs. To all body organs. Therefore, you expect that these groups, they will have non-selective action. Non-selective action. Okay? Because they will act on all body organs. They will inhibit sympathetic tone to all body organs. In this case, they will have widespread action. They will have action on every organ in the body, as you will see later. Okay? Therefore, group 1, which is centrally acting, group 2, which blocks the ganglia, group 3, adrenergic neuron blockers, they block the sympathetic activity to all body organs. Therefore, they are non-selective in their action. That's why these drugs, they are generally known to produce what's known as sympathoplegia. 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 Sympathoplegia means paralysis of the sympathetic nervous system. They produce paralysis of the sympathetic nervous system. They produce sympathoplegia because they will affect all body organs. Okay? So we expect that this group of drugs, they have very limited clinical uses. Clinical uses and they're under very close medical supervision. Specific clinical uses. Okay? So these are the three groups. Group 1, alpha-2 agonist. Group 2, ganglionic blocker. Group 3, adrenergic neuron blockers. And these three groups, they are produce paralysis of the sympathetic activity to all body organs. That's why they are known as sympathoplegics. Okay? The fourth group, they act on the adrenergic receptor, on both synaptic adrenergic receptor, whether they are alpha or beta. Therefore, they might be an alpha blocker or beta blocker or both. Okay? And the fourth group, which is very specific and very selective in their action, they will act on adrenergic receptors on the postsynaptic membrane. They might be an alpha blockers or beta blockers or both, blocks alpha and beta. These are known adrenergic receptor blockers. Adrenergic receptor blockers. Adrenergic receptor blockers. Therefore, adrenergic receptor blockers, we expect that they will be more specific and more selective than the other three groups because they will act specifically on one adrenergic receptor. They will not produce general sympathoplegia as the others do. Okay? So the first group are the adrenergic receptor blockers. They either block an alpha receptor or they block a beta receptor or they block both. There are three different groups. And in this case, these drugs, they have more selective action. Why? Because they will produce actions related to the receptor they block only. They don't produce general sympathoplegia. Okay? So these are the classification of sympatholytics. They are classified into 4 groups as we have said. Okay? Now, so we'll talk first about the first group, which are the centrally acting sympatholytics. Centrally acting sympatholytics. These drugs, we have said that they act as alpha-2 agonist. They act as alpha-2 agonist. We always said that alpha-2 are inhibitory. They lead to inhibition of the sympathetic activity. Why? Because they decrease the formation of cyclic AMP, and therefore they decrease the intracellular calcium. This affects centrally, especially in the medulla. This is the medulla, which is the lower part of the brainstem. This alpha-2 activity in the medulla will decrease sympathetic outflow, As we know that there is a continuous sympathetic outflow centrally, which goes down the spinal cord and terminates in the organ. This we have called sympathetic outflow. There is this continuous tone to different body organs from central, which controls peripheral activity through the sympathetic nervous system. Okay? Now, these drugs are alpha-2 agonists, as we have said. They are inhibitory. They inhibit the flow. This flow will be inhibited. That means they will inhibit the flow to all organs of the body. That's why they produce sympathoplegia. Okay? These drugs, sympathoplegia. In this case, what do you think? They will have a selective effect or a non-selective action? They will have, of course, non-selective action, because they will inhibit sympathetic outflow to all body organs, including the GIT, the cardiovascular system, the heart, including the heart and blood vessels, pupil of the eye, mouth, sexual organs, all will be affected. In this case, they will produce non-selective actions or widespread action. Okay. These drugs, how they inhibit sympathetic activity by inhibiting sympathetic outflow to the different body organs. By doing this, they produce general sympathoplegia, which is paralysis of the sympathetic activity. Therefore, they are non-selective in their action, i.e., they will have widespread action all over the body organs. Okay? So, for these, their use is very limited and indicated only under certain clinical conditions, as we will see later. Okay? So, let us take example of this group of drugs. Let us take some example. The first, most famous example is Methydopa. Methydopa, actually, it is a prodrug. It is a prodrug. As we have said before, prodrug means that the drug is not active until it is metabolized to active metabolite. Methydopa is metabolized to methyl noradrenaline. Where this happens, it happens at the adrenergic nerve terminal. So methydopa will enter the adrenergic nerve terminal. It will be methydopa. It will be utilized by the adrenergic nerve terminal. Instead of L-dopa, it will be converted to methyl noradrenaline. Okay? Methyl noradrenaline. Methyl noradrenaline is actually, it's known as a false neurotransmitter. A false neurotransmitter. As we have said, the adrenergic nerve terminal, usually what is stored? Noradrenaline, which is released. Correct? Instead of noradrenaline, methydopa will enter the nerve terminal and it will be converted to methyl noradrenaline. Methyl noradrenaline actually is a weak adrenergic neurotransmitter. That's why it is known as false neurotransmitter. Therefore, methydopa will produce false neurotransmitter, decreasing sympathetic activity, because the noradrenaline will be absent. Sympathetic activity. Okay? So methydopa, first example, very famous methydopa, which is known as Aldomit as well commercially. Methydopa is a prodrug. It is converted in the adrenergic nerve terminal. It enters the adrenergic nerve terminal, where it is utilized instead of L-dopa, and it is converted to methyl noradrenaline. Methyl noradrenaline will be released instead of noradrenaline as a false neurotransmitter. This will result in decreased sympathetic activity. That's how Methydopa works. Okay. The second example we'll take are Clonidine, very famous Clonidine, guanfacine, and guanabins. Okay, so the other examples: Clonidine, most famous, guanafacine, guanabins. These three, they are direct alpha-2 agonists. Okay, so as we have said, that alpha-2 is inhibitory. It will decrease sympathetic outflow to the periphery and therefore increase sympathetic activity. Okay. So these are the examples, most famous examples. Methydopa, which is a prodrug converted to methyl noradrenaline in the adrenergic nerve terminal, where it will act as a false neurotransmitter, decreasing sympathetic activity to all body organ. Other examples: Clonidine, guanafacine, and guanabins. They are direct alpha-2 agonists. They decrease sympathetic outflow, as we can see here. They decrease the flow which comes from central to the peripheral to all audio. This is a tonic flow. It's always active. Sympathetic activity controlled centrally from the central nervous system. If this flow decreases, means the sympathetic activity in the periphery will be decreased. This will produce, as we have said, sympathoplegia. Okay? Now, so what we expect will happen? If we decrease the sympathetic outflow to different organs? So we talked about the drugs and how they act. Now we'll talk about the action. All of them, most of them, except for a few actions, all of them, they produce similar action. All of them, they produce, as we have said, general sympathoplegia. So what do you think will happen? Let us take the cardiovascular system first. What will happen to the heart? The heart, as we know, it has a certain sympathetic drive which drives the heart, as we have known, through the vasomotor centers in the medulla and the cardiac centers. The cardiac centers will activate the heart, increasing the heart rate. In this case, if we decrease the sympathetic activity to the heart, what will happen to the heart? Decrease actions of all the heart, including rate of the heart will be decreased. This will produce bradycardia and decrease force of contraction. Okay, so these drugs, they can produce bradycardia, but they can decrease contraction. If they decrease contraction, what will happen to the cardiac output? Decrease the cardiac output. If cardiac output is decreased, what will happen to the blood pressure? Decrease in blood pressure. Because as we have said before several times, blood pressure is the product of two factors: peripheral resistance multiplied by cardiac output. This will determine blood pressure. Blood pressure is determined by the peripheral resistance in the arterioles and how much the heart is producing blood, cardiac output. So if we decrease the cardiac output, that means we decrease blood pressure. This is the first action on the heart. So centrally acting sympatholytics on the heart, they will decrease sympathetic activity at the heart, decreasing sympathetic action, decreasing rate, producing bradycardia, and decreasing contraction, and decreasing contraction will result in decreasing cardiac output, especially of the ventricles, of course, contraction of the ventricles, and this will result in decrease in blood pressure. This is first. On blood vessel, the same thing will happen. Also, blood vessel, we said, it is blood vessels, they are controlled by alpha-1 activity, especially in the skin and the viscera. It is controlled by alpha-1 activity. So if there is no alpha-1 activity, if sympathetic activity is decreased, what will happen to the blood vessel? Vasodilatation. Okay? Because if we just imagine this is the blood vessel, and this is the adrenergic nerve which supplies the blood vessel. As we have said, the activity will come through the ganglia, ending at the adrenergic nerve terminal, releasing noradrenaline. Noradrenaline will act on alpha-1 receptor, reducing vasoconstriction. We have said that several times before. Correct? Now, if we block sympathetic outflow, there is no sympathetic outflow. That means there is no release of noradrenaline from the nerve terminal. So what will happen to the blood vessel? Blood vessel will be dilated. Vasodilatation. Vasodilatation. So this is second action of these drugs on the blood vessel. They produce vasodilatation. And if vasodilatation takes place, what will happen to the peripheral resistance? Decrease. It will decrease peripheral resistance, especially in the arterioles. And if the peripheral resistance decrease, بيحصل decrease in blood pressure. Decrease in blood pressure. Okay? So blood pressure by sympatholytics is decreased by two mechanisms. By decreasing the cardiac output and by decreasing the peripheral resistance. Okay? So we'll expect that this group of drugs will be used in treatment of high blood pressure. High blood pressure, which is known as hypertension. Of course, they are used, but under very close medical supervision and for certain conditions, as we will see later. Okay? So this is first action of these drugs. Okay? Now, when these drugs, they decrease the peripheral resistance, especially in the arterioles, they produce what's known as postural hypotension. Postural hypotension. Okay? Now, so what will happen in this case? So these drugs, we have said, they decrease the peripheral resistance. Once they decrease the peripheral resistance, suppose that person is in the lay down position and decided to stand up suddenly. So what will happen? All the blood will be collected in the periphery, depriving the brain from blood. This will produce dizziness, or what's known as postural hypotension. Postural means change of posture. Change of posture. As a change of posture وضع مستلقي إلى الوقف مثلا. Change of posture will result in hypotension. Patient will feel dizziness and he might faint. Dizziness because there is no blood reaching the brain, or very little of the blood reaching the brain, because the blood is pooled at the periphery, producing dizziness وممكن fainting in the severe cases. Dizziness and fainting. Therefore, a postural hypotension, is it a good effect or it is a bad effect? It is a bad effect, therefore it is a side effect. Very common side effect of these drugs. So these drugs, they are able of producing postural hypotension. Why? because they decrease the peripheral resistance. In that case, the person, when he changes his position, he will suffer from postural hypotension. Okay? This is a very common side effect. This will decrease the compliance. People who are treated with these drugs, they will not like this effect. Every time they stand up, they feel dizzy and they might even faint. Therefore, they will hate using these drugs. This is one common side effect. Another common side effect, they will decrease the sympathetic activity due to gastrointestinal tract. As we have said, the sympathetic activity of gastrointestinal tract, they are excitatory or inhibitory. We said they are inhibitory. They inhibit intestinal activity. So what will happen in this case? If sympathetic activity, that means parasympathetic will become predominant. If the parasympathetic become predominant, this produces diarrhea. This is a common side effect. Not all of them, because one or two of them, they don't produce effect. Like in general, these drugs, by inhibiting GIT, sympathetic activity to gastrointestinal tract, the parasympathetic will become predominant, because as we know, GIT, there are two activities. Autonomic activity. Autonomic, as we have we said repeatedly, autonomic controls the unconscious functions of the body, the functions in the viscera, the gastrointestinal tract. Cholinergic, they are excitatory. Cholinergic drugs, they are excitatory. They increase the activity in the gastrointestinal tract, increase the motility, and increase the contraction of smooth muscles of GIT. While the sympathetic, adrenergic, we said they are inhibitory. They are inhibitory to the gastrointestinal tract. Therefore, these two usually they are in balance. In normal cases, they are in balance. Now, what I have done with these drugs, I remove the sympathetic activity. Sympathetic tone to the GIT is decreased. That means cholinergic activity will become predominant. If the cholinergic predominant, that means diarrhea. This is side effects. As I have said, not all of the drugs that we have mentioned produce diarrhea. Some of them, they produce constipation by a natural effect. Okay? So this is a side effect. Second effect on ejaculation in male. Ejaculation in male, it is alpha-1 dependent. It depends on alpha-1 sympathetic activity. Therefore, if we decrease the sympathetic activity, what will happen to the ejaculation in male? Ejaculation will be inhibited. This is known as a failure of ejaculation. Failure of ejaculation. Okay, this is very, very bad side effects in male. Okay, so these are most of the actions as we have seen, and there are other actions on the eye. For example, the same thing, meiosis will take place. Why? Because cholinergic will become predominant, producing meiosis, and so on. So they will affect most organs in the body. They produce many side effects. That's why these drugs, they are known to have low compliance. What does it mean, low compliance? That means the patient does not adhere to the therapy because of the many side effects. Okay? Usually these drugs, they have low compliance. That's why they are used as second or third choice. In certain cases, as we will see later, they are used as second or third choice in the treatment of hypertension and other clinical indication. Okay, so these are the actions of centrally acting sympatholytics, which are alpha 2 agonists. قلنا they produce general sympathoplegia, therefore they produce many side effects, and these many side effects will decrease compliance. Okay, now so let us take their clinical application. Their clinical application, as we have said, they are selective in their clinical application. They are not first line treatment except in certain cases. So let us take the first example. Methydopa. We said methydopa is converted to methyl noradrenaline, which acts as a false neurotransmitter. Methydopa indication is only indicated in treatment of hypertension in pregnancy, either alone or with other drugs. Hypertension in pregnancy, which is known as gestational hypertension. So methydopa indication is only indicated in treatment of hypertension in pregnancy. It is safe. They found it is safe for the fetus and the mother. Okay. Clonidine, on the other hand, second drug, clonidine, it is used as a second line therapy, either alone or in combination. Second line, as we will see when we talk about treatment of hypertension, there is first line, there is second line, and there is third line. So clonidine is second line in therapy of hypertension. Why second line? Because, as we have said, it has many side effects and patient compliance is low. Okay. Also, clonidine in treatment of hypertension, we have to take one consideration, that if clonidine is stopped suddenly, if the patient is treated with clonidine and the physician decided to change the drug and stop clonidine suddenly, this might lead to a phenomenon known as rebound hypertension, which is very dangerous. Rebound hypertension. Okay, this is a problem of treatment with clonidine. Therefore, clonidine, if it is used, never to be stopped suddenly. Why? Because if we stop it suddenly, blood pressure will go up very acutely, and this is very dangerous. This is known as rebound hypertension. Okay. The clonidine, what is used for treatment of hypertension, it is used as second line. Why? Because of many side effects and low compliance. And it is either used alone in combination with other drugs, as you will see when we talk about antihypertensive drugs. And in this case, if it is used, it should be used carefully and should never be stopped suddenly because of the rebound hypertension. Okay. Other uses of clonidine, it is used to treat withdrawal symptoms from drug of addiction. Withdrawal symptoms from drugs like alcohol, like barbiturates, like opioids, morphine, heroin, methadone, etc. Clonidine is used to decrease the severity of withdrawal symptoms due to drug of addiction like alcohol, like barbiturates, like opioids. Why? Because in these cases, the withdrawal syndrome will result in the activation of the sympathetic nervous system. Therefore, clonidine in this case, by decreasing sympathetic activity, will decrease severity of the withdrawal symptoms, will decrease the severity of withdrawal symptoms. Withdrawal symptoms like mydriasis, like like diarrhea, like tremor, etc. So, clonidine in this case, they are given to decrease the severity of the withdrawal symptoms due to alcohol, barbiturates, and opioids. We'll discuss that in details, inshallah, in the near future. Guanafazine, specifically, it is indicated, guanafazine. It is indicated in treatment guanafazine. This is the third example. So we talked about Methydopa, we talked about the Clonidine. Third example, guanafazine indication. It is indicated in the treatment of hypertension as well as a second line. And also it is indicated for the treatment of attention deficit hyperactivity syndrome, which we talked about, or a disease, which is known as ADHD. ADHD, attention deficit hyperactivity disease, ADHD, in which the person, especially young children and young adults, they show very high motor activity that will prevent them from learning. So these drugs, guanafazine, it is one of the indications in the treatment of this ADHD syndrome. Okay? So these are the first group, which are the centrally acting sympatholytics. Okay? The second group are the ganglionic blockers. Ganglionic blocker, they block the autonomic ganglia, whether it is sympathetic or parasympathetic. As we have said before, that nicotinic receptors they are present at the ganglia, and they are known as nicotinic receptor type N, and they are present at the neuromuscular junction and they are known as nicotinic receptor type M. These drugs, ganglionic blocker, they block the nicotinic receptor at the ganglia. They are competitive antagonists at the nicotinic receptor of the autonomic ganglia. Therefore, they will block both the sympathetic and the parasympathetic ganglia. This is the parasympathetic ganglia, and this is the sympathetic ganglia. So these drugs, they block both types of ganglia, whether it is sympathetic or parasympathetic. That's why it's known as autonomic ganglia. That's why these drugs, they will have a widespread action. They will block all autonomic activity. This widespread action will produce many side effects. Some of them, they are intolerable side effects. Therefore, they will have very limited clinical use, very limited clinical uses. Okay? So ganglionic blockers, they block autonomic ganglia and they produce many side effects, and that's why they have very limited clinical application. So these drugs, what they do actually, they block both ganglia, and the final effect will depend on the predominant ganglia. Final effect of this drug will depend on the predominant ganglia. The ganglia which has more activity at the specific organ. For example, on the gastrointestinal tract, the predominant ganglia is parasympathetic. The parasympathetic system is the predominant autonomic effect on the gastrointestinal tract. That's why you have continuous high tone in the intestinal smooth muscles. Okay, so in this case, if we block the parasympathetic ganglia on the GIT, ganglionic blocker will produce constipation, because as we know, cholinergic activity at the GIT always excitatory. Cholinergic activity, parasympathetic, is excitatory. They increase the peristalsis at the smooth muscles of the GIT. Therefore, if this peristalsis is decreased, this will produce a constipation. So this is a very common side effect. Okay. Now, on the cardiovascular system, as we have said, the predominant is the sympathetic. So the sympathetic system is predominant on the heart, on the blood vessels. So what will happen to the heart? Reduce bradycardia, because blocking the sympathetic ganglia, which goes to the heart, this will decrease adrenergic activity, producing bradycardia. This is one effect. On blood vessels, the same thing. Blood vessels tone is controlled by sympathetic activity. If we block sympathetic activity, will result in vasodilatation. These two effects will decrease blood pressure, as we have explained earlier. Okay, and this is one of the application of ganglionic blockers, to decrease blood pressure in certain conditions, as you will see later. Okay. Now, for example, on the eye, produces mydriasis. Why mydriasis? Because the parasympathetic ganglia is the predominant on the eye. Parasympathetic produces meiosis. If we block the parasympathetic, what will be left? The sympathetic, which produces mydriasis, dilatation of the pupil. Okay. Okay. Their effect, most common effect, by decreasing blood pressure, by decreasing the peripheral resistance through the baroreceptor reflex, they produce postural hypotension. This is all drugs which we have mentioned before in the today's presentation. They produce postural hypotension due to the baroreceptor reflex. So they decrease the baroreceptor reflex, and this will result in postural hypotension. This is a side effect. This is a side effect. Okay. So as we also on they produce block of the parasympathetic innervation or parasympathetic activity to the venous, and they produce failure of penile erection. This is a side effect as well. It has no clinical application. It is a serious side effect which can induce low compliance. So that's why ganglionic blocker, they have very limited clinical use when they are used, ganglionic blocker, because of the many side effects, because they block the autonomic ganglia, they produce many side effects. So what they are used for? They are kept for certain condition when there is hypertension accompanied by dissecting aortic aneurism. Dissecting aortic aneurism. What happens in the aortic aneurysm? There is an aorta, the large artery, which runs large artery. Usually, in some cases, it suffers from aneurism. Aneurism in which the walls of the aorta becomes very thin. It forms a balloon-like. If this ruptures, it causes bleeding, and bleeding can lead to death. So in this case, it is an emergency case, and they have to lower blood pressure in order to operate, to make operation removing of the aneurysm, surgical operation. Okay. So usually in this case, they give trimethophan. Trimethophan. This is the drug of choice in this case. The trimethophan is given in surgical operation of dissecting aortic aneurism to decrease the blood pressure and to prevent bleeding as a result. Okay. A second use of trimethophan, this is one indication in dissecting aortic aneurism accompanied by hypertension. Second, it is the second line in treatment of hypertension crisis. Where there is no first choice. The first choice in this case is sodium nitroprusside. Sodium nitroprusside. If sodium nitroprusside is not available or because of its toxicity after its long use, as we will discuss later, in this case, trimethophan is used to lower blood pressure in hypertensive crisis. Okay. Also, sometimes it is used when sodium nitroprusside it is used during the operation to lower blood pressure if the blood pressure rises. So these are the ganglionic blockers. They have very limited clinical use in the treatment, and there is only one clinical example with approved clinical uses, trimethophan. It is used in cases where there is dissecting aortic aneurysm to prevent the bleeding and to proceed with the surgical procedure in removing the aneurysm. Third group are group that will act on the adrenergic nerve terminal. They are known as adrenergic neuron blocker. So if we imagine this is the adrenergic nerve terminal, these drugs either they prevent the storage of noradrenaline, as we have said in previous presentation. Noradrenaline, after it is sensitized, it is stored in the storage vesicle. So some drugs they prevent the storage of noradrenaline. This is one group. This is first group, group A. A second, they prevent the release of noradrenaline. This is group B. So adrenergic neuron blockers, we have two groups. Group that will prevent the storage of noradrenaline, or group that prevent the release of noradrenaline from the adrenergic nerve terminal. That's why they are known as the adrenergic neuron blockers. Okay. The first group we are going to talk about are the adrenergic neuron blocker that prevent the storage of noradrenaline. We have one example in this case. Reserpine. It is a natural alkaloid. It is obtained from a natural plant, reserpine. Reserpine, what does it do? It prevents the storage by preventing the uptake of noradrenaline into the storage vesicle. By preventing storage, what will happen? بيحصل depletion of all monoamines, not only noradrenaline, all monoamines. As we have said before, monoamines, they are either dopamine, 5-HT, and adrenaline, noradrenaline and adrenaline. These are the monoamines. So reserpine, by preventing the storage of the monoamines, they lead to depletion of all the stores of monoamines. This will have peripheral effect and central effect. Because reserpine is highly lipid soluble, it can penetrate the brain very fast. So peripheral effect by depletion of noradrenaline from the adrenergic nerve terminal, معناها produce decreased sympathetic activity. This is sympatholytic effect. طبعا decreased sympathetic activity everywhere. So it will produce exactly the actions we have described for the centrally acting and for ganglionic blockers. So they inhibit sympathetic everywhere, including decrease in blood pressure. As we have said, decrease in blood pressure due to decrease in cardiac output and vasodilatation. This effect, that's why reserpine one time ago it was used, not anymore, except in very rare cases. It was used. It is third line therapy. شو معناها third line? If the person is not responding to any first line therapy or second line therapy, then we try third line treatment. Okay? If the reserpine is kept as a third line in the treatment of hypertension. Why? Why? Because of many side effects. What are the side effects? Central effects, which are peripheral and central effects. Peripheral and central effects. Peripheral effects, exactly the side effects we talked about early, which are produced by the alpha 2 agonist or ganglionic blocker, exactly the same side effects. Centrally, the reserpine, it has a central effect because, as I have said, it can penetrate the blood-brain barrier and it can deplete dopamine and 5-HT centrally, and of course, and noradrenaline. Depletes all. Depletes معناها removal. Complete depletion معناها removal, because the monoamines will be broken down by MAO, as we have explained many times before. Because we have said that the adrenergic nerve terminal, all monoamines should be stored in the storage vesicle. If they are not stored, MAO is ready to metabolize the monoamine oxidase. This enzyme present in the cytoplasm, it will break or oxidize any monoamine free. So the monoamine, if it's not stored, it will be metabolized by MAO. That's why reserpine prevent the storage, so the monoamine will be available for the monoamine oxidase, which it will oxidize it and metabolize it. Okay, so now all monoamines will be depleted centrally. So what will happen if we deplete 5-HT and dopamine and noradrenaline? This will lead to mental depression. This is very common, mental depression. نسموه الاكتئاب النفسي احنا. اكتئاب النفسي, mental depression. So by depleting 5-HT and noradrenaline, reserpine can produce mental depression. This is a very common side effect, and it is unpleasant side effect. Okay. Also by depleting the dopamine in the nigrostriatal pathway, it will produce Parkinsonism, مرض الرعاش, as we'll talk about them later inshallah. It produces Parkinsonism by depleting the dopamine. Depleting معناها removal, depletion, تفريغ, عملية التفريغ. If there is no dopamine, this will result on overactivity, cholinergic overactivity through the extrapyramidal tract, that will result in Parkinsonism, which is very bad side effect. Okay, so that's why reserpine nowadays it has very little use because of the severe side effects, including peripheral side effects and central side effects. It is only kept as a research tool. It is very important research tool in the search for antihypertensive drug, and as well it has very limited clinical use when blood pressure cannot be controlled by other safer drugs. Okay, so these are the first group of the adrenergic neuron blockers, are drugs which prevent the storage, and we have only one example, which is reserpine. A second group, there are drugs which prevent the release of noradrenaline. The second group we are going to talk about are drugs which prevent the release of noradrenaline. This include very famous example. The most prototype is guanethidine. This is the prototype of the group. guanethidine, guanethidine, betanidine, betanidine, debrizoquine, and guanadrel. Guanethidine, betanidine, debrizoquine, and guanadrel. There are other examples, but these are the most famous. Guanethidine, most famous. We never forget guanethidine, betanidine, debrizoquine, and guanadrel. What they do, these drugs, what they do, they enter the nerve terminal first by uptake 1 mechanism. I have explained what's uptake 1 mechanism several times before. Uptake 1 is responsible for the uptake of noradrenaline, physiological inactivation process of noradrenaline. So these drugs, they enter the nerve terminal first, and then first they will displace noradrenaline from the nerve terminal, and noradrenaline will be exposed to monoamine oxidase. So the first effect will be depletion. If these drugs, they are uptaken by the uptake 1 mechanism, they have to enter the nerve terminal. That means if we inhibit the uptake, they cannot enter the nerve terminal, and they lose their antihypertensive effect. Once they enter the nerve terminal, they displace noradrenaline from the storage sites, making it free in the cytoplasm. Once noradrenaline is free, it will be metabolized by monoamine oxidase. This will cause depletion. This is the first effect. The second effect, these drugs, they have a local anesthetic-like action. Local anesthetic-like action on the nerve terminal means inhibit a release. Inhibit a release. So actually they have a dual mechanism of action. First, they enter the nerve terminal, causing the depletion of noradrenaline store. Depletion of noradrenaline. Second, they have a local anesthetic action. They inhibit the release. Local anesthetic action, that means they block sodium channels at the nerve terminal. And in this case, the noradrenaline will not be released. Inhibit the release. These both two actions will decrease sympathetic activity. In the same way we have described before, because it will inhibit sympathetic activity everywhere, including all organs, all internal organs. That's why it can produce sympathoplegia, like a first group. We talked about. Okay, so these drugs actually, they have very limited clinical uses because of this first reason, sympathoplegia, and second, because they produce many drug interaction. If they are taken with other drugs, they might produce very severe drug interaction, as we will say later. Okay, so these drugs which prevent the release, they act by dual mechanism. They inhibit. First, they produce depletion of noradrenaline stores. Second, they produce local anesthetic action, and therefore they inhibit sympathetic activity everywhere, including the heart. They produce action similar to those we have described for the alpha-2 agonist. Okay, plus these drugs, they have drug interaction with many classes of drugs, as we will say later, and that's why they have very limited clinical use. So these drugs usually they are second or third line in the treatment of hypertension. They are second or third choice in treatment of hypertension, as we will say later, because treatment, as I have said, hypertension, there are first line drugs, there are second line drugs, and there are third line drugs. So these drugs, they are usually third line drugs when the person is not responding to first line drugs or second line drugs. Okay, so these are the third group, adrenergic neuron So we talked about three groups: centrally acting alpha 1 agonist. So in summary, we can say that we talked about first group, centrally acting. This drug will produce general sympathoplegia, resulting in widespread action and many side effects. Methydopa is the drug of choice in pregnancy, and we said that clonidine has clinical use in treatment of hypertension and to decrease withdrawal symptoms due to drug of addiction like alcohol, like barbiturates, and like morphine-like drugs. Second group, ganglionic blockers, when they block autonomic ganglia and they lower blood pressure acutely, and that's why they are used in hypertensive crisis and dissecting aortic aneurism. They have no other clinical application because of the many side effects. Third are storage depleters, which are reserpine-like drugs, and they are used in the treatment of hypertension, which are resistant to other type of therapy. Lastly, adrenergic neuron blockers, we have said, they have very limited clinical application in hypertension because of the low compliance and drug-drug interaction. Low compliance because of the many side effects produced by these type of drugs. They are third-line choice. So by this we have finished talking about the part 1 of sympatholytics. In the next lecture, we'll talk about part 2 of sympatholytics, and this includes the adrenergic receptor blockers, which have very important clinical application. Inshallah, we'll talk them in our next presentation. I would like to thank you very much for your attention. If you like my presentation, don't forget to subscribe. Please distribute to all your colleagues and friends and other students. I hope that you stay in good health and prosperity. Wassalamu alaikum wa rahmatullahi wa barakatuh.